what I'm going to do is talk about a number of different issues around dolutegravir-based ART regimens, and hopefully zip through all of this to allow lots of time for questions. But I'll give you an overview about considerations around antiretroviral drugs, women and children. We'll talk about dolutegravir and birth outcomes. I'll provide an update very briefly on dolutegravir safety and efficacy, review the guidance on dolutegravir use, a global update on the TLD rollout, and then some implementation considerations. So a number of years ago, dolutegravir was identified as an optimal antiretroviral, particularly tenofovir, lamivudine, dolutegravir as TLD, for use in low and middle income countries. And in 2015 WHO guidelines moved dolutegravir TLD into the position of alternative first-line regimen. We're unable to make it the preferred regimen because at the time there was not enough information around use of the drug in pregnant women and in HIV-associated TB. And over the next several years, a lot of work was done to try and provide this additional data. So when we're thinking about antiretrovirals and pregnancy or women and children, it's all about timing, the timing of exposure, the timing of the outcome, as well as the nature of exposure. So when the ARV exposure occurs, is it at conception, early in pregnancy, late in pregnancy, or during infancy through breastfeeding? When the outcome occurs and is identified, again, is it during pregnancy, at birth in the newborn period, or at any time during the pediatric development? And also the mechanism of toxicity, recognizing that the molecular basis of birth defects, in particular with drug exposure, is only known for a few drugs. Also, keeping in mind that there's a broad array of other factors that could impact child outcomes, including maternal HIV infection, nutrition, and environmental factors. Now, when we think about ARV exposure and child outcomes, what are we looking for? And as you can see here, there's actually quite a long list, starting with fetal loss, stillbirth, neonatal and infant outcomes, deaths, congenital anomalies or birth defects, which we'll talk more specifically about, including neural tube defects, compromised birth outcomes. Early complications have been described with ARV exposure in infants, including mitochondrial disorders, hematologic abnormalities, abnormal neurologic development, and a number of other complications. And then late complications, including organ dysfunction, neurocognitive abnormalities, and malignancies. So these just to set an understanding that ARV and HIV exposure during pregnancy can have multiple ramifications, and that it's not just about birth defects per se. But as we're thinking about birth defects, it's important to understand the timing of in utero ARV exposure and fetal risk. And what you see here is a timeline of the development of the fetus from conception to the full-term infant. And the first 2.5 weeks post-fertilization is called the pre-organic period, and that period is generally not sensitive to teratogens. As you move on, weeks 3 to 8 to 12 post-fertilization, embryogenesis occurs with active organogenesis, and this period is actually the most sensitive to teratogens. And the neural tube in particular closes generally around day 28 post-conception, and that's during teratogens during that period can result in myelomeningocele or teratogens affecting oral structure formation might lead to cleft palate. As you follow the timeline and get into 8 to 12 weeks, after 8 to 12 weeks post-fertilization, you have further fetal development with fetal growth, teeth develop, external genitalia, and of course the brain continues to develop. And that's where you will begin to see the effects of pathogens like alcohol and fetal alcohol syndrome or smoking, which leads to intrauterine growth retardation. One other important sort of background piece to understand as we think about birth defects is that the ability to rule out an increased rate of birth defects is related to the defect incidence and the number of observed preconception or first trimester exposures. So as you can see here, with 200 exposures, you can rule out a twofold increase in overall birth defects when the background incidence of the birth defect is about 3%. However, to rule out a threefold increase in a rare event like neural tube defect, which has an incidence, estimated incidence of about 0.1%, you need about 2,000 exposures. And this is important to understand as it gives you some background in understanding the data that we'll review a little later, and also about thinking about how to monitor for birth defects. So let's talk specifically about dolutegravir, birth outcomes, and birth defects. So I think everybody is familiar with the birth surveillance study, the Botswana Tsepamo study. This study was designed to evaluate the risk of neural tube defects with preconception efavirenz exposure. For the old timers, you might remember that there was concern 10 or 15 years ago that was not fully resolved until 2014, that efavirenz exposure at conception increased the risk of neural tube defects. And this study was set up initially to monitor for birth defects, particularly neural tube defects with efavirenz exposure, and to examine pregnancy and birth outcomes by ARV exposure. Prospective birth outcomes surveillance is done for major surface birth defects, 8 large maternity wards that cover about 45% of all births in Botswana. The hospital-based midwives are trained to do surface exams. A research assistant consents mothers for photographs if a birth defect is identified, and then a clinical geneticist reviews all diagnoses. And they have a large number, a good denominator of control groups, and an ability to distinguish between ARV regimens, timing of ART initiation, and infant HIV exposure. And of particular note, in May 2016, the Botswana government shifted first-line ART from TLE, or the efavirenz-based therapy, to TLD. The study provided important information about birth outcomes among women receiving dolutegravir. And as you can see here, birth outcomes are similar for women who start dolutegravir during pregnancy when you compare them to women starting efavirenz during pregnancy. The rates of birth outcome, any adverse event in that top row was similar between the two drugs. And as you look at individual outcomes, including prematurity, small for gestational age, stillbirth, and neonatal death, they're similar by drug. It's also important to note that the rates for both dolutegravir and efavirenz adverse events are generally higher than rates of these outcomes in women who are uninfected with HIV and not receiving any antiretrovirals. So in May of 2018, WHO convened the Guidelines Development Group to consider whether dolutegravir in combination with age-appropriate backbone should be recommended as the preferred first-line, as well as preferred second-line antiretroviral agent for treatment of HIV infection. And in preparation for that, that meeting, materials were gathered to look at all of the evidence around use of dolutegravir in pregnancy. And the Tsepamo study was asked to take a look at their data around conception exposure. So in May 2018, they reported to the guidelines group that they had identified 86 neural tube defects among 88,755 births for a rate of approximately 0.1%, including 42 meningomyelocele, 30 anencephaly events, 13 encephaloceles, and 1 enencephaly. 22, or a quarter of these neural tube defects, occurred among stillbirths. Among the live-born babies, 40% died within the first month of life. And just as background information, the estimated prevalence of neural tube defects in 2015 globally was estimated at 0.19%, or 18.6 per 10,000 live births, and with great variation geographically. An estimated rate of 0.09 to 0.14% in sub-Saharan Africa. When they looked more closely at their findings, they determined that there were 4 neural tube defects among 426 women who had dolutegravir exposure at conception, for a rate of 0.94%. This compared with 3 of 5,787 exposures of efavirenz at conception. And if you go all the way down to the bottom, compared with 0.09% among HIV uninfected women. And in this slide, you can see the same information looking at the percentage with 95% confidence intervals with neural tube defects by ARV regimen, with the light blue, with the light blue being dolutegravir, and across all of the other exposures, you can see low rates, and that the confidence intervals for the dolutegravir conception do not overlap. Well, almost immediately thereafter, every major organization put out a statement informing the potential safety issue affecting women living with HIV using dolutegravir at the time, and providing the information about these 4 cases of neural tube defects and this higher rate and a potential risk of increased risk of neural tube defects in women taking dolutegravir at the time of conception or early pregnancy. WHO, the FDA, the EMA, PEPFAR, and ViiV, the manufacturer of dolutegravir, all put out safety warnings within days of the information being released. In July, at the IAS meeting, the study team was able to update their findings, which had been presented in May. From May through July, there were 2 additional neural tube defects identified, one in an infant exposed to dolutegravir starting during pregnancy, and 1 birth to an HIV uninfected woman. The updated prevalence of neural tube defects among women with dolutegravir exposure at conception was 4 over 596, or 0.67%. So was indeed lower than what was presented in May, but the 95% confident intervals still did not overlap with any of the other exposure groups. In the figure below, you can see that there was no evidence that there was any clustering at specific sites or at any particular month or time of these defects. So this finding may be a random event or a cluster, or it may be an early signal of an increased risk of neural tube defect associated with dolutegravir exposure at conception. The study has expanded from 8 to 18 sites in Botswana. Real-time monitoring is now occurring with every 200 exposures. The next planned analysis is the end of March, where they're expected to capture 1,226 births with dolutegravir exposure from conception. There are limited data from other sources like the Antiretroviral Pregnancy Registry, the FDA, post-marketing surveillance, and they're of limited value given incomplete reporting and limited numbers. It's of note that Brazil, which also moved to dolutegravir for first-line therapy, is undertaking a retrospective chart review of births to women with ART at conception, including efavirenz, dolutegravir, and raltegravir. We hope to see those results in the spring as well. So I'll now turn briefly to an update of dolutegravir safety and efficacy. In the summer AIDS meeting, the Dolphin-1 study presented their findings. Dolphin-1 was an open-label randomized clinical trial of dolutegravir plus 2 NRTIs compared with efavirenz plus 2 NRTIs in 60 pregnant ART-naive women presenting late to ANC at greater than 28 to 36 weeks gestation in Kampala and Cape Town. And of note, the notable findings were the median time to RNA less than 50 copies was approximately halved with dolutegravir compared to efavirenz. This was a secondary endpoint of the study, but is actually quite critical because one of the goals around prevention of mother-to-child transmission is to reach undetectable viral load by delivery, and these data suggest that dolutegravir will get you there much faster. In an intent to treat analysis, there is a significantly greater proportion of dolutegravir than efavirenz subjects who achieve viral suppression by 2 weeks postpartum. In preparation for the May WHO guidelines meeting, they looked at the safety of dolutegravir and efavirenz 600 in first-line ART and updated the systematic review and network meta-analysis that had been done for the previous guidelines, and were able to demonstrate that dolutegravir had performed better on outcomes of viral suppression, treatment discontinuation, and CD4 recovery with moderate, high, and moderate levels of evidence. They were comparable, the two drugs were comparable on mortality, AIDS progression, and serious adverse events. The AIDS meeting, Brazil presented their outcomes using routinely collected data among over 100,000 individuals who had initiated ART. And as you can see here in the top line, individuals who initiated ART with TLD were significantly more likely to achieve a viral load less than 50 copies at 6 months post-ART initiation compared to efavirenz based antiretroviral treatment. And if you continue to look down, you'll see that the PIs perform significantly less well compared with efavirenz. And this was, rather than a study, this was all observational data collected from routine data sources. About 75% of individuals had a viral load at the 6-month time to be included in this analysis. And then more recently, just several weeks ago, the results of the ANRS 12313 NAMSAL study were presented at the Glasgow meeting. And this was a comparison of TLD versus TLE 400 rather than the 600 that we generally use. 616 patients, 2/3 of whom were women, were randomized 1-to-1 to dolutegravir versus efavirenz 400 plus tenofovir and 3TC at 3 sites in Cameroon. And the primary endpoint was non-inferiority of dolutegravir versus efavirenz 400 by proportion with viral load less than 50 copies at week 48, and an intent to treat snapshot analysis with a 10% margin. And very briefly, you can see here that TLD was determined to be non-inferior to TLE. The overall viral suppression rates were 74.5% with TLD and 69% with efavirenz, not meeting their inferiority margin. Of particular note is that the rates of viral suppression for both agents varied by baseline viral load. And you could see in the bottom row that viral suppression at 48 weeks was only achieved in approximately half the individuals at 48 weeks among those who started with a viral load greater than 500,000 copies. Of note, there were similar rates of adverse events and AIDS-defining illnesses between arms, and no treatment interruptions attributed to intolerance. And this is particularly important because in previous comparisons, there were more adverse events and treatment interruptions due to intolerance in the efavirenz 600 arms. So now let's shift to talking about guidance on the use of dolutegravir. So after coming to terms with the new data on neural tube defects, WHO did publish interim guidance on antiretroviral therapy and recommended a dolutegravir-based regimen as the preferred first-line regimen for people living with HIV initiating ART for adults and adolescents, women and adolescent girls of childbearing potential, and infants and children who improved dolutegravir dosing, and included a note of caution on using dolutegravir during the preconception period for women and adolescent girls of childbearing potential. When you drill down, however, and look a little more closely at the details of the specific regimen, you'll find that there are actually 2 different first-line regimens recommended, with dolutegravir for women and adolescent girls of childbearing potential with consistent and reliable contraception and who are fully informed of the benefits and risks of dolutegravir use, whereas they continue to recommend efavirenz for women who do not have consistent and reliable contraception. The guidelines also included information about the importance of adopting a woman-centered approach that took into account promoting human rights and gender equality and addressing the needs and perspectives of women and their families as critical to determining appropriate ARV regimens. PEPFAR has also been developing guidance on the use of dolutegravir, and their guidance recommends dolutegravir-containing regimens as the preferred first-line therapy, and that programs should rapidly transition to TLD as the preferred ART option. Populations recommended to transition include all new adolescent and adult first-line populations, all existing adult and adolescent first-line populations, patients failing NNRTI-based first-line ART or have failed ART and are currently on a PI-based regimen, in programs that can confirm virologic suppression 3 to 6 months after transition. Also, adults receiving rifampin-containing regimens for TB, and pregnant and breastfeeding women. PEPFAR recommends that TLD counseling on the potential benefits and risks of the drug, including NNRTI resistance, drug availability, maternal and infant toxicity profiles should be provided, along with access to voluntary family planning services to women of reproductive potential to help them make an informed decision about their ARV regimen and use or non-use of family planning. So the new guidance represents a major change in the approach to ART scale-up. I think we attribute much of the success of the rapid global ART scale-up to the simplified, harmonized public health approach. One pill once a day to everyone starting treatment. Well, we now see a shift from the one first-line regimen harmonized across populations to 2 first-line regimens, with the regimen potentially being determined by individual characteristics like the sex, reproductive potential, the choice of the women. There's also a shift from a public health to more of a patient-centered approach. Regimens have historically been determined at a national level, and now we're introducing patient choice as a determinant of regimen. WHO and PEPFAR guidance represent somewhat different approaches, recognizing they both speak to the importance of informed choice. And ART use is now linked with sexual and reproductive health, as well as another commodity, in this case, contraceptives. And globally, we recognize that contraception prevalence rates are low and unmet family planning rates are high. And here is just a slide demonstrating contraceptive prevalence rates in women 15 to 49. In the first bars, it's any method. In the middle, it's modern contraception. And third column is unmet need for family planning. The red bar is East and Southern Africa, and purple in West and Central Africa. So we're seeing uptake of family modern methods of only about 35%, and a clear unmet need over 20% of women. So we'll shift now to the global update and implementation considerations. So as we try to put together the guidance and think through the various options that country programs may be considering for introducing dolutegravir, there are a variety of different approaches. Starting at the top, one could have TLD for all adults and adolescents. As you go down, TLD for all adults and adolescents, with women of reproductive potential having an option to choose TLE. You can choose to have TLD for male adults and adolescents, and women of reproductive potential choosing to use effective contraception, but reserve TLE for women of reproductive potential choosing not to use effective contraception. Another approach is TLD for male adults and adolescents, and TLE for female adults and adolescents of reproductive potential. And then finally, TLE for all adults and adolescents, keeping what many countries are currently doing, and reserving TLD for special populations like individuals with TB or those on legacy regimens or for third-line use. This is a recent update prepared by WHO of different country guidance on the use of dolutegravir-based regimen for women specifically. You can see that many countries have opted not to make dolutegravir available to women of childbearing potential. However, you'll also see that a number of countries have chosen to allow TLD use among women with who have any or long-term contraception. Several countries are providing TLD to everyone, and as well as counseling on contraception and informed choice, but relatively few. If we look at pregnant women, for the most part, pregnant women are not yet will not yet be able to access dolutegravir, except perhaps for a few countries in the second and third trimester. And this is just an illustrative example of a prescribing algorithm for TLD use in females that was being developed in one country. And as you can see, first you document pregnancy, and then if the woman is not pregnant, you would explore childbearing wishes, offer contraception, and based on these various steps, make a decision around which regimen to offer. So certainly some level of complexity around identifying regimen and the woman and who can get which regimen. WHO has also begun to develop some guidance to help countries identify the major factors that can influence the transition to dolutegravir in first-line ART. And in particular, you can see that there are a number of clinical and epidemiologic concerns, the percent of women of childbearing potential, patients on suboptimal regimens, availability of second and third line options, and pre-treatment drug resistance. There are a number of important concerns around commodities, existing stock, access to contraceptives, access to viral load, and then of course all the program and policy issues that need to be addressed. Thought I would focus on a couple of specific considerations for the transition to TLD, and then open it up for discussion and conversation. So, and some of these issues were identified in the survey that was sent out. So trying to be responsive to some of the issues that have come up. So is Dolutegravir is safe for women of childbearing potential, and there is no yes or no answer here. It's a balance of a possible increase in risk of neural tube defects with the potential benefits of TLD, which include better tolerance, more rapid viral suppression, higher rates of viral suppression, projected lower transmission to partners and infants, and no worse birth outcomes. What's the rate of pretreatment HIV drug resistance in a given setting? This is really quite important to consider. If population level resistance to efavirenz or nevirapine is greater than 10%, WHO guidance suggests a rapid transition to non-NNRTI-based first line. Alternative options for this rapid transition include TLD or protease inhibitors. We're all well aware of the many limitations of protease inhibitors. And then, is it necessary to measure viral load prior to switching patients from current first-line regimens to TLD? And really, there's no strong evidence on which to base this policy. Recognizing viral load availability is rapidly increasing, but still not widely available. Is it critical to measure viral load prior to transition? You could transition those with viral suppression to TLD, and those with unsuppressed viral load would potentially transition to dolutegravir with 2 other NRTIs, or you could transition everybody to TLD and then measure viral load 3 to 6 months later to confirm viral suppression. And these represent 2 different approaches, one that WHO has put forward and the other that PEPFAR is suggesting. So we have to think about ensuring access to consistent and reliable contraception. Access to contraception varies across and within country programs. There's a potential for new threats to family planning access with expanded Mexico City policy. User fees may further impede family planning access in some countries, and options may be more limited in faith-based settings. And the current issues, however, provide an opportunity to think about how to enhance family planning access and services. Family planning contraception is traditionally provided within the MCH, so there's a critical importance of considering integration within ART programs where women will be accessing ART, and also how one thinks about family planning access in the context of differentiated service delivery models of care. And also we have to acknowledge that substantial numbers of women living with HIV want more children, and women are often not the only decision makers around contraceptive use. How do we enable women to make an informed choice? How do we effectively communicate concepts of risk to the individual and the community and link risk with ART choice? The burden around education and communication will likely fall to the facility health workers who already shoulder a heavy burden of HIV response. They're traditionally guided by algorithms. Our experience communicating risk and supporting patient choice are limited, but the experience for the old timers around AFAS and determine infant feeding options was highly unsuccessful. Effective training, mentoring tools, and ongoing support for healthcare workers will be essential. We've fooled around here at ICAP along with others trying to identify ways of communicating this risk of neural tube defects to women or to communities. Here you see trying a visual approach. Ordinarily, of every 1,000 babies born, we would expect to see 1 neural tube defect, the yellow dot in the fourth line. But for women taking dolutegravir, we may see 6 or 7 babies out of every 1,000 who could have a neural tube defect. How would information like this be understood within a community, low literacy communities, or by women? We do not yet know, or the most effective way to communicate this information. What should countries be doing to monitor for neural defects and other outcomes? Well, surveillance for birth defects and other rare outcomes is difficult and costly. There's a global need to implement birth outcome surveillance systems. However, it has to be rigorously done to provide meaningful data. You need to have those denominators to know all of the birth outcomes and to make sense of the ones that you find that are abnormal. The dolutegravir neural tube issue should make countries consider the importance of birth outcome surveillance and what might be appropriate for a particular setting. And technical assistance is available to inform and support implementation. Monitoring systems also are generally already in place to measure uptake, efficacy, and the impact of transition to new regimens. But systems to monitor drug-related adverse events for individuals taking are weak and need to be strengthened. And other critical life events like pregnancy and breastfeeding are also not routinely recorded in patient files or EMS and clearly warrant attention. There are a number of resources out there. There have been several cost-benefit analysis for TLD that have been completed and presented, and several are in press. WHO is developing implementation guidance. We will be posting and disseminating a healthcare worker training in the next weeks. There are a variety of tools and materials under development, and the Tsepamo team is working diligently to continue to obtain high-quality data to further inform the neural tube defect question. There are several external groups have also been convened to evaluate and analyze all of the available data on an ongoing basis. So I'll conclude and then open this up. The findings of a possible association between dolutegravir and neural tube defects as derailed plans for the rapid rollout of TLD as the preferred ART regimen. Country programs are facing a number of complex issues around TLD use and implementation, and there's fairly limited experience on which to build to help address these issues. But there are also enormous opportunities to address these issues and to continue to improve health outcomes for people living with HIV. I think we could do this best by learning from each other, and the collective experience will clearly inform future work. Currently, I think we all feel like we're between a rock and a hard place, as you see in this picture, but hopefully over time we'll figure out how best to do this. Thanks.
Great. Thank you so much, Elaine. That was a fantastic presentation. So as mentioned, we're going to open it up for questions and answers now. I don't think that we've had any questions come into the chat box. So if you do have questions and you want to type them into the chat box, you can do so. You can also raise your hand if you want to ask a question out loud by clicking participants and raise hand at the bottom right corner of your screen. And then we can unmute you ourselves. And then we'll also give you the option if you want to chime in yourself, you can unmute yourself by clicking your microphone icon at the bottom. Just please be sure that no one is already speaking and there's no background noise on your end.
So it's been suggested that I review what we can anticipate will happen over the next several months in terms of research findings and programmatic data, and what programs can do to monitor this issue within their programmatic work. So I think that we're anticipating more information from the Tsepamo study that will be available ideally or as projected at the end of March, where they expect to have over 1,200 dolutegravir conception exposures, and that number will bring them, depending on whether or not there are any additional neurotube defects, should give them enough exposures to determine whether this is a random signal or whether this association is indeed true and strong. It may not be enough data, but we're expecting more information, more helpful information by the end of March. In the meantime, as I mentioned, Brazil will be reporting back on their exposures and experiences, or so we anticipate, but noting that that's from a retrospective chart review, which holds different value. Information on exposures is continuing to be collected in the Antiretroviral Pregnancy Registry and other post-marketing surveillance sources. So all of those are being looked at regularly and help augment the database, so to speak. So in terms of what countries can do, it's a tricky question around the neural tube defects, because it appears that most countries are taking a somewhat conservative approach and not routinely, women are not going to be offered the option to take dolutegravir. So potential exposures during conception and early pregnancy are likely to be few. So a number of countries have surveillance systems, birth surveillance systems in place, and in those settings it will be really important to particularly focus on the dolutegravir outcomes. But overall, there's probably not any immediate action steps around collecting this information in settings where there are no current plans to roll out dolutegravir to women of childbearing potential. So someone is asking, how should national programs interpret the findings of NAMSAL trial on the TLD transition? Looks like TLE 400 did better than TLE 600. So I provided that information because it was just released, and but it's only been presented in abstract form and has not been peer reviewed or widely disseminated. So the first caveat is probably early for national programs to respond in any way. I also want to note that it was not a head-to-head comparison between TLE 400 and TLE 600. It was a comparison between dolutegravir and TLE 400. So I don't think we can say that TLE 400 performed better than TLE 600. You would have needed to have had that a third arm to be able to say that. Probably the most interesting finding was the difference in viral load suppressions for both drugs across baseline viral load, and the low rates of suppression amongst individuals with higher viral load pre-ART. So somebody is providing some information about anticonvulsants. That's Shoba, thank you. The Kenyan guidelines say do not use dolutegravir, barbiturates, phenytoin, and carbamazepine, but it's not an option of other anticonvulsants, double the dose. But there's no practical experience on this. Tegretol has similar effects as the rifampin, so decreases the level of dolutegravir and should be avoided when using Tegretol or give extra dolutegravir. So it looks like for the anticonvulsants, you would increase your dolutegravir dosing. So why is Botswana continuing to give dolutegravir while Eswatini and others are not? Are we overreacting? I won't pass judgment on overreacting or not reacting. I think that Botswana is very clear about their assessment of the overall risks and benefits to their population. They've had a very good experience to date with dolutegravir, and I think that while I can't speak for them, I think that they've, in their risk-benefit analysis, have chosen to stay the course until we have more data and this association is clarified. And other countries have made that decision. And I also can't speak to what Eswatini has decided, but as you saw in one of my slides, the majority of countries appear to be taking a more conservative approach before providing TLD to women of reproductive potential, awaiting further data before rolling it out to both men and women. Oh, somebody is recommending the Liverpool site for looking up drug interactions, and also the U.S. Public Health Service antiretroviral guidelines have some lovely tables that also outline the same thing. So, and I apologize for not having had that information up on hand.